Hello, everyone, and welcome to the last of our 3 eConsults webinar series. My name is Mandy Ashley. I'm the Executive Director of the Aurora Health Alliance. This is co-hosted by the MHHA Health Alliance. Just a reminder for everyone, please keep on mute during the presentations today, but do be active in the chat with any questions and discussion items. So first we'll be hearing from Dr. Fred Thomas, who's the Director of Telehealth Services at Children's Hospital, Colorado, and the Executive Director of Peer Mentor Care Collaborative. From Fred, we'll be hearing about ECHO Colorado and the PMCC. Following that, Heather Logan, the chair of the Aurora Health Alliance, is going to be leading a discussion on next steps for all of us as it relates to eConsults. Okay. Fred, I will advance the slides for you. Thanks.
Great, thank you. I appreciate you all joining us today. And I think I'm really excited that you all have decided to take this on related to kind of informing the state, informing your care alliances about the possibilities of eConsult, because I think we find ourselves right now in a very unique time, an opportunity post-COVID related to any number of individuals and entities figuring out what telehealth might do for them, and then the idea of will these stick around? Will these rules stick around? How can we use it best? And what are the other options that we might have relative to expanding access to specialty care that could be efficient and effective? And so that's kind of the purpose of today's talk. And please, as Mandy said, please do park in there questions you have, comments, and if I run out of time, or if you think I want more information or papers or something, you can forward those to me and I'll be happy to respond to them after the talk. So please go to the next slide. Many of you have been, this is my 8th year in Colorado related to working to expand telehealth and ECHO and eConsult. And it's always been to me kind of a mystery why we've thought about these things in separate kind of stalls, without the idea about how one might benefit the other, or how they would augment each other, or really at the end of the day, the idea about how do we get to right care, right place, right time sort of perspective with the ability to use these different tools. Now, all of them aren't perfect, obviously, and each have their limitations and their barriers. But the others in combo, I think, sort of complement the other, and maybe can perhaps deal with some of the barriers that one of the other models have. So if you see this slide, and I'm more than happy to share a larger version of it for you if you'd like to read all the items below, but you get at the kind of the idea about how they fit together. And the in-person model, because none of this is meant to replace in-person care. And to kind of say you should do this only tele, but it's meant to sort of augment when it's appropriate, related to not really replacing in-person care, but providing access at the patient's convenience, if you will, for the right place, right time, for the right level of care. So in-person and tele, we pair those together with the idea that those are specifically telemedicine modules that allow for in-person visits between a provider and a patient, or a provider and a group of patients. Where the other models, where ECHO and eConsult come in, where it's indirect, where it's more of a peer-to-peer or a peer-to-a-group-of-peer sort of model, and with each of those sort of complementing each other. And I'll go into more of this as we move on. Would you go to the next slide? So telehealth in itself, I mean, I think, again, with COVID, there's a whole lot of more people that maybe some that dipped their toe in, and many that kind of said, okay, we're jumping into the deep, cold end of the pool because we have to. And so whether that's right or wrong, the idea about telehealth is just really the use of technology to expand access to care or the access to education or information to improve knowledge around care. So it includes all these different sort of mechanisms that we're showing here, as opposed to just sort of the traditional versions that many sort of assume telehealth includes. So next slide, please. So I'm sure any number of you, ECHO has been in Colorado for, I guess, 6 years at this point. We've done training and interactions all across the state in almost every county. I think we're missing a couple of counties at this point where there's not been a provider or an entity who's participated in an ECHO. But I think around 100 different disease states, you know, anything that you could imagine. An ECHO in Colorado is a little bit unique and different than what it had been in other states, and that was kind of from design, with ideally at the beginning about how we were initiating ECHO in the state. And from the beginning, we really wanted to focus on how could we go around the state and try to interact with different geographies, different payer groups, different care providers, and say, what is your relationship with the university and the hospitals there? And what is good, what is bad, and where is it that your patients don't get the access to care that they need? And that's where the idea was from the beginning, is to try to figure out how we integrate ECHO into the academic medical center, partner with different entities around the state to focus on the partnerships and to build these different models out. All along with the idea that ECHO was just sort of a piece of it, not was sort of the answer all, or that it was the magic pill that was going to solve everything, but really as kind of a piece of a puzzle where we were focused on building out a broader spectrum of options around tele-enabled care. Next slide, please. And that is the next slide. Oh, there we go. Okay, maybe I thought maybe I'd double up. So again, related to ECHO, and if you don't know, I can share more of these different things with you. But it's more the idea of a force multiplier, with the idea, if any of you, for those who have not participated in ECHO, where you would have the ability to come into a session where you have a panel of experts who are presenting information about a disease state or a health topic. And then the individuals like yourself who are participating can sort of present their own cases in. Each can learn from each other and build out their model, and also build a cohort of support to build a community of practice, if you will. So you see this slide over there where in, I guess in 2019 alone, I should probably add 2020 because we've done the big COVID just-in-time ECHO that's I think has had its 55th session this week. Still focused on trying to promote primary care's management of COVID in their practice. And at the beginning, we were having about 500 providers a week coming into this. And at this point, I think we have several or a couple hundred that are still, it was 3 times a week at the beginning around in March. And at this point, I think we have it twice a week with topics that you can participate in the learning network, and then also present your ideas or thoughts or questions about managing COVID in your practice. So I think that in itself has had about 4,000 participants in it since March. But on the other topics, disease topics from depression to pediatric management of mental health conditions to asthma to autism to all those different things, in 2019 alone, we had 1,800 plus providers who participated in ECHO, free of charge, obviously, for them to come in and get the ability to share their knowledge and build capacity in their practice. The statistics below really try to get at the point. I know Aurora is not rural, but it's focused on how do we expand access and knowledge to rural and frontier as well, with the idea that participants in these areas have been higher as their percentage of the ECHO participation than they are as far as a percentage of the state. Still, with large number of the participants participating from the urban areas. Next slide. Um, the other piece is you start seeing how these all come together in the PMCC is the eConsult model. Many of you have probably participated in eConsults in the old traditional way, which might be a curbside chat or a provider at the medical center, and you text them or email them or call them and say, hey, Bill or Janet or whomever, will you see this person or should you see this person? That really, for people who know people well and have a good connection, can be somewhat efficient, but it's really hard to sort of replicate that. And for those who don't have the connections or who there's not a provider that answers calls like that, can lead to a really inefficient practice model, as opposed to an idea where you built out a better framework for making it efficient. So the core model of our eConsult is built on templates and all the different disease states that allow for a provider to go in and ask a question, and then to be told by the specialist provider at the academic medical center, here are the questions you need to answer in order for me to give you an appropriate feedback about whether or not that patient could be seen at your PCP, oh my goodness, the poo's about to hit the fan. So how about you give me some more information, and that'll lead for a more informed referral to the academic medical center with a better access to care. Again, the idea of making it more efficient and to be an iterative process that sort of builds on itself and builds a community and builds knowledge. Next slide. So for the last couple of years, we've had quite a few eConsults happening. Over 6,500 eConsults have been placed, 4,100 unique patients. Many of the Colorado counties, again, but not all of the Colorado counties. And while we're looking for data related, and we're working with Medicaid to produce a study right now of eConsult enabled specialty care visits in a certain range of specialties compared to another set of specialty visits that are non-eConsult enabled, and doing cost comparison in that realm. The data that we have largely right now are related to the time saving, the financial savings of the patients not having to schlep to the academic medical center. And then the idea from a safety and or care quality component, less than 2.5% of these eConsults result in a specialty visit after, because the level of care wasn't sufficient enough in the primary care to manage the care scenario. And then the other end related to safety is that we've had 0% of these resulting in an ED visit. And this is not just over really simple questions. This is over, I think, 28 different specialties from a range of different conditions. Of course, this is not heart surgery that's happening on a picnic table in Cortez, but it's more, it's the and I don't mean to pick on Cortez, but it's the appropriate level of care in an iterative process driven by communication to allow for more care to be done by the primary care partners in partnership with the academic medical center. Next slide. So as you think about the eConsult model and you think about ECHO, the idea of those from the Peer Mentored Care Collaborative, it made a lot of sense to tie those together in a way where if you had a number of providers doing eConsults, that at the end of the day, they could come into a highly coordinated sort of ECHOs series to help drive sort of better high value care and to reduce low value care and to promote education amongst a set of PCPs so that they can do more care in their practice. Again, getting back to the idea of a medical neighborhood, a better informed medical neighborhood, allowing for more care to happen in the PCP where it should happen when it's appropriate. Next slide. There's a lot of words here. I think I've said all of these things. But again, it's sort of the idea of moving beyond the sort of curbside discussion, but a more formalized kind of process that ideally would make it, pardon me, more efficient for both ends of the spectrum, and for the patient themselves to have more ability to sort of drive their where they receive their care. So there's many who have a really great relationship with their PCP. They end up going to the academic medical center or can't get into the academic medical center. And that's certainly you know, data that we see for Medicare and Medicaid populations with a lower access to specialty care, and then their condition worsening without their ability to kind of get the care that they need. So this again is built on the idea of actually trying to have this sort of ability to promote more specialty care, to be more efficient in it. Because believe it or not, there's any number of conditions like rheumatology or some of the others where you have a limited number of providers at the academic medical center. And if 40% of their visit totals are filled by people who are not procedural or who don't need to be at the academic medical center, that's inefficient for the AMC as well. So the idea of right care, right place, where folks that could be seen virtually or in partnership with the PCP could be done that way with the information sharing, and the appropriate level of care is done at the AMC, hopefully saving money for all involved, including the system. Next slide. So there's a number of different conditions that I think, and I'm sure if anybody has a question about how would it work here, or have you thought about this, be more than happy to review those kind of things and think about that sort of model. But a specific example of where we've done some work with funding that we've had at the academic medical center is to focus on one issue is with pediatric asthma with the Denver Health School District, where the idea was to allow for a pediatric pulmonologist who said, you know, part of my time is paid by Denver Health. By the time I drive over there and park and get into there, I'm 15 minutes late. The patients don't get seen. They've shoved more patients into the clinic slots, and then no one gets the appropriate level of care. So promoting that through telemedicine-enabled care, with the idea that that's backed up by ECHO, where the school-based health nurses have the ability to kind of build their community of practice, to practice more with more capacity in their own school setting. So you could see how that could work and could scale to other scenarios. I always love to talk about diabetes and both 1 and 2, with the idea that if you look at the American Diabetes Association, or the idea for the best level of care is 4 times a year with a board certified endocrinologist. Well, many people with either self-pay or who have Medicaid or who live remotely just can't do that. And so why should they get lesser level of care? And for those who are managed quite well, why should they come to the academic medical center 4 times a year and not have their diabetes managed in their home or at their PCP? So this model has a great opportunity to kind of do both ends of that with especially those who are managed quite well. Make them, have them come to the academic medical center 1 time a year, and you do your broad, and this is not AMC standard. Let me put this is my idea, not what's happening just yet. But why wouldn't we have a well-managed diabetic come to the academic medical center 1 time or twice a year, have their big visit, and otherwise, if they're managed quite well, either go home or have their PCP do a visit with them with a telemedicine-enabled interaction, or have their PCP say, "Hey, Mrs. Johnson, could I manage your diabetes in partnership with the folks at the Anschutz campus? I'm going to enter your data," and they'll send us data back, and I'll communicate through email or through your medical record and say everything's going well. Don't worry about it. And we just managed it better that way and more efficiently that way. Again, better examples of here, and we have papers on all this stuff. So if any of you want to see academic papers with data to demonstrate how this works, be more than happy to share. Next slide. And how am I on time, Mandy?
Vicente, how are we doing? He is keeping time for us.
Yes, actually, I just sent you a 2-minute warning. So.
Okay, I think we're almost there. So in effect, what we have here is we have the ability of offering a range of options And as Medicaid is reviewing their desire to continue to expand or to communicate an expansion of access to specialty care, but worrying about the cost of it related to the costs or the issues around COVID for the state budget. These other models, eConsult and ECHO, offer an opportunity to partner with PCPs to allow them the capacity to do more care in a tele-enabled model, and to allow their patients to get access to specialty care, and to do that again at the right time, right care, right place, that sort of idea. And again, many times you might hear the medical campus is here, or I'm here from CU and I'm here to help you. Well, some people might kind of scratch their head what that means, but this is really the idea. We're in this together to push more appropriate care to the PCP in partnership with the academic medical center, a bi-directional approach. Next slide. And I think I've already shared all the different lessons learned, what we're talking about, but again, we can share these different things with you, and you could say, tell me about that lesson because I didn't hear it. But I think I've shared most of the topics here. Show the next slide, please. Next slide. Wondering if then going back to the model again about how these fit together and complement one another to again drive the idea home of a bi-directional partnership approach with PCPs to lower the cost of care where appropriate, and the right level of care when it needs to be at the academic medical center can be, and when it can be at the PCP or the patient's home can be there as well. But to focus on how do we provide the right set of tools to allow this to be a cost-effective and efficient process that provides the right level of care for the patient. Next slide. Okay, so I think you all have heard from Matt Thompson, who answers questions much better than I do, I think, because I go into a different direction. But Matt's information is here. I also answer questions and will answer email if you'd like to send me one. But with that, I think I'll close and hopefully open up for questions. Thank you.
Thank you so much. Fred, I think you and I met like maybe 5 years ago when you were talking to Denise and I about ECHO, and it was way over my head, and now it's slightly less over my head, but
well, at the time I remember that because I drew a picture of this on a napkin for Denise, sort of very much like this is how it fits with all the arrows, and then at some point our staff said, you know, you write too messy, you talk too fast. So let's put this on a slide so it makes sense to anybody. And so I would,
it's pretty clean.
Yeah.
I like it. Okay. People have been typing questions in the chat and sending them to Vicente, who is my co-leader on this eConsult series. So Vicente, take it away with questions.
Yes, so we got a couple questions here. One question that was asked is, how are physicians and specialists getting reimbursed for eConsult service, or is this strictly collaborative?
So very good question, and you know, we start off with a stump the chump question. So that's one of the limitations currently of the eConsult mechanism is that Medicare does pay for eConsults, and we are trying, the study I mentioned a minute ago that we're hoping to get data to Medicaid by the end of the year was to demonstrate the efficiency of the eConsult efforts so that they also turn on the codes and allow for this to happen, and so providers would get paid for that type of care. But currently, that is one of the limitations of this, is the lack of reimbursement for it. There are UPL efforts that are happening on the campus in partnership with specific disease states where the providers on both ends, the PCPs and the specialists, get paid through UPL dollars, but those are relatively limited. But if you have thoughts or ideas or would like to talk about other opportunities, we'd love to talk to you about that.
All right. The next question that came in is, do you have any specific strategies to help ensure individuals living in rural and frontier communities, making sure that they have adequate access to broadband, which has traditionally been more challenging in those areas?
Yeah, and I can completely concur. I was talking to Kevin Stansberry over on the Eastern Plains today, and he was talking about any number of people in their home or settings who don't have access to the broadband to do the more complicated, to do the full expansion of telehealth as has been advertised about do this at do it by telemedicine because it's paid for. This is where the other pieces related to the eConsult and Echo may come in, where they require lesser broadband to participate in those levels of and interaction. But that's still an issue in some parts of our state, and I think there are a few federal pockets of money that are coming through currently that may actually try to mitigate some of that, but it is certainly still an issue that has to be dealt with, because if we don't do that, we can't really say that you have access wherever you live. I concur, it's still an issue.
Hey Fred, this is Heather Logan. I just heard an interesting article from Colorado Public Radio that in Telluride, they received some funding for vans to drive around that put out Wi-Fi or broad, like, so people can go near that van and connect their computer or their phone. And they drive these vans around the community and park them in certain spots and let the community know where they're going to be. Yeah. And if that works well, they're hoping to replicate that in other parts of like rural and frontier Colorado, so people have access to that. Yeah. So it'll be interesting to see if that commuting internet becomes more popular in those communities.
Yeah, I mean, I applaud everything that does something for outreach. I mean, at the end of the day, that seems like it's hard to scale, and it's also is like, oh, because how long is that van going to be parked? You know, how long do you have that van parked down by the river? I mean, that's a bad, old Saturday Night Live joke, but it's just hard to scale that, the idea about how you would do that and how much access it actually does improve. But anything that sort of adds to, I agree. But I think we still have to get at how do we actually do things that require lower levels of broadband in some ways and through some of these other mechanisms, and to also expand access to broadband across the state.
All right, we have a couple more questions. One question that was asked is there any behavioral health e-consults for either adults or children?
Let's see. There are. Please do kind of follow up with me on that. I know the Department of Psychiatry has started to move toward this idea of actually doing this sort of work in e-consult land. And I know also that COPCAP, which is a program that Sandy Fritz runs through the Pediatric Mental Health Institute, also has some aspect of e-consult that's available. The other thing, we actually have done 6 or 7 or maybe even 8 different cohorts in ECHO for pediatric mental health management with primary care, and trained about 130 providers through that. And we'll continue to do that work and continue to focus on how do we expand access to behavioral health. At the end of the day, though, as many of you know, that gets down to access. And if you have someone who's in crisis or you get an answer from the academic medical center, that's a real problem. And there's no access to care. That doesn't really solve your problem there. But we are focused on how can we actually provide more access to care through the behavioral health aspects, and there's just not enough yet.
And Mandy, do we have time for one more question? All right, I got that.
Sorry, I'm nodding. And
Yes.
I think a couple questions came into Joe as well.
All right,
So-
Joe, you know what? I'll let Joe ask one of the questions then. How about that?
Sure. Yeah, one of the questions was, can everyone access eConsults outside of UC Health?
Currently, no. So what has happened, where it is stage-wise, is the core program was started as in partnership with the American Academy of Medical Colleges to focus on inside Epic encounters. And then right at the end of the SIM money from the state, we actually got some money to do an external pivot to partner with Frontier de Salud to focus on how could you have a Epic developed eConsult transferred to a non-Epic health information record and sort of have that sort of work efficiently. And so that pilot is going on currently with Frontier de Salud. And we're also looking at other options where we could actually turn this external with other partnerships as well. But again, this is related to, it's hard to get both ends of that care spectrum involved if they're not being paid for it. So this is part of the data that we hopefully will have with Medicaid and other payers by the end of the year, and allow that to, and convince Medicaid to pay for that. I see that there's on there that Kaiser does have external, and those are, I think, relatively limited, but they are external. For uninsured patients, it seems like that may be it, and I may be wrong there. And then Denver Health actually has an eConsult program, but that seems like within their system as well. But I think all of us working together to demonstrate the efficiency and the effectiveness of this can and convince the payers, not wholly that, gosh, we're going to turn on a code for another thing, but we're going to do it because it makes sense and the care's good, and it costs less. I think those are the trinity that will help us get there. Another one?
Vicente, did you have one more question?
Yeah, there's one here. Do patients pay for eConsults via copay or whatnot?
Yeah, so that payment sort of work is being worked on right now with the idea that it would not impact the patient in a way that would be any different than their copay. And so that question, I would like to actually get the exact right answer because it's a very touchy thing to kind of communicate. So post this talk, I'll huddle with Matt and we'll get the exact information that could be parked out there to the audience here so that they know exactly what that looks like. And that's with all of this. So if you have questions or things that you think of afterward or this afternoon or concerns, please do communicate and I'll answer all of those things and they can park my answers back on some central site that people can have access to.
Thank you.
Yep.
Thank you so much, Fred. Our whole goal of this series has been to level set and to build momentum in support of eConsults, eConsult reimbursement, and support of the organizations that are providing these services, even without some reimbursement. So we certainly appreciate it.
Yeah. Well, we would certainly, for the folks who are talking about Kaiser and for Denver Health, I mean, if we can collectively demonstrate a willingness to kind of play in the sandbox together and to demonstrate how we kind of do this collectively, or to like there's an aspect of I know Kaiser sends a whole lot of requests to for pediatric sort of expertise to children's. If there's a way where these other entities say, well, what we really need is blank, blank, and blank. And then we could actually sort of try to figure out how we could work together on covering each other's limitations, maybe.
I know in our next segment to wrap up the series, we're going to be talking about next steps, but certainly health alliances are a way in which we can get partners and champions to play in the sandbox together. So that's something we're definitely willing to do, even if it's compiling, data for you all. Well,
Great, thank
from
you.
you all, I should say.
Well, thank you.
I know that it's lunchtime and people are probably eating lunch right now, but if you are listening and you're on and you have the ability to turn on your camera, we're just going to take a few screenshots so we can share the success of this. Otherwise, it'll just be your name. So we're just going to take a moment to do that. Thank you.
You want to be incognito.
Oh, that's fine. Wear your mustache. And then you guys can go back to your anonymity. That's fine. All right, we got a few more. Bobby Joe,
Mandy, should we do like a 1, 2, 3 smile kind of thing so everyone's kind of like on the same page?
or look very confused. No, just
Yeah.
kidding. Engaged. Show your engaged face. Okay, 1, 2, 3. Thank you so much. Good idea, Vicente. Okay, moving on to the next section. Thank you so much, Fred. I know if we were in person, people would be clapping. So next steps, Heather. Heather did a virtual clap. So Heather, I pasted the questions that we had talked about just on the slide. I know it's a lot of words, but if people want to read these and kind of think about them as you guide us through it, thought that might be helpful.
Thanks, Mandy. And thank you, Fred. That was a wonderful presentation. I feel like every time I listen to work around eConsults and the Peer Mentor Care Collaborative, I learn a little bit more. So thanks for presenting today. I have to say, last night, I was talking to my 98-year-old grandmother. She turns 99 next month. And I was talking to her about eConsults and kind of explaining what they were and about today's presentation. And it's just interesting to hear, from her perspective, what medicine looked like, when she was in her teen years, in her 20s, 30s, and 40s, with a doctor coming to your home to assess you, or her living in rural North Carolina, where going to the hospital was like a trek. So it's just interesting to see over time, like this is where we are with medicine. It's becoming more e-driven. And the whole world of telemedicine isn't going to stop. I think it's just going to continue to advance and grow. So I think it's really important that we have these conversations on how we can help with that work advancing, because we have come very far, thinking, 50, 60, 70 years ago. But I think we still have a ways to go in terms of some of the things that Fred mentioned around reimbursement, some of the policy work. How do we expand this? So we wanted to talk to all the stakeholders today on the Zoom, just around how we can kind of collectively move the work forward and how we can support the work that's already happening. So what is already happening in Colorado with eConsults as it relates to advocacy or policy, research, reimbursement, and is there a role for the Alliance to play in some of that?
I'm thinking you want other people besides me to talk, yes?
But you're so connected to it. We can hear
Yeah.
Yeah, I think it's good just to hear, because some people, I think, are learning about eConsults and the Peer Mentor Care Collaborative for the first time. And so it's, well, how do I get involved in this? And what should my organization be doing? And then I think that there's some people that probably are a little bit more advanced in it and more in the weeds as it relates to policy or advocacy, or want to get involved. So are there things happening in that arena, Fred? Are you aware, just around the policy or advocacy piece?
Oh, certainly. So I think, there's a lot of, frankly, and this is sort of being prepared doesn't happen by accident, if you will. So the idea of having a telehealth framework, or having been doing the echo stuff, or having the eConsult thoughts about how we would do these sort of efforts well before they were reimbursed at the level that they are now, prepares us to kind of be in the spot. And whether right or wrong, Medicaid and the other payers at this point saw this gigantic growth of telehealth during the COVID period of time. And now they're looking at, with the idea, could we continue to expand this access to specialty? And can we do it safely, securely, with the right level of care, but can we do it in a way that doesn't break the bank, especially when the state is really kind of having a hard time financially related to COVID, et cetera. And so how could this all work? And so basically, I think the time spent setting all of this stuff up and demonstrating data and having papers around this sort of work is advocacy in itself. And us having done all of that stuff through grant funding prior to this last year, and the university going, okay, we recognize that we need to do this as well. So maybe this would be appropriate to use the UPL funding that's available to allow this to happen in partnership with Medicaid, because at the end of the day, it is about expanding access to specialty care. So by and large, most of this work at this point is funded through UPL dollars, with the idea that this will allow for expanded access to specialty care. So that's that. I think I mentioned very briefly the research that we're doing currently with Medicaid to look at specialty conditions that are enabled by eConsult compared to those that are not, and look at the outcomes of care and the cost, so that we actually can demonstrate the cost benefit of that. And so that's the idea from a research perspective. And then frankly, advocacy and research going together with good data will hopefully lead to a policy change which will have the payers, Medicaid and private payers, willing to pay for this. I don't think that happens unless we can show that it's done in a way that's responsible. Again, I'd like to focus on the system approach, which is what we're focused on, is instead of the one-off Teladoc or American Well or eConsult that's not connected to a system. Because at the end of the day, you want it sort of connected with the providers who you would see in person or who you would see via telemedicine, not by somebody who's remote somewhere else, that doesn't sort of connect it into trying to keep the cost contained and provide the right care within the state of Colorado. I hope that makes sense.
Great. Thank you, Fred.
I think for me,
I was just gonna say, others have thoughts. Go ahead, Vicente.
Yes, I think for me, it's just like, I think Fred mentioned that, there's certain hospital systems, or whether or not there's like limitations that people are facing. It's like, okay, what can we do to kind of help, fill in those gaps? And when I heard that, I'm like, okay, what are some, what can a health alliance do? Like, what are the questions we can ask other health facilities like Denver Health or Centura that kind of hits that question of, okay, what are gaps that you need help with, so that we could kind of reach out to other institutions to see if we can, assist in any way. And so I don't know the answer to that, but, that's one way in which health alliances can have these kind of conversations and kind of collaborate in kind of this kind of working group.
Yeah, I like that.
Yeah.
Yeah.
I connected with HCPUF before this, mid-level HCPUF, not big HCPUF. And there are a ton, and we've heard this at the Aurora Health Alliance Access to Specialty Care groups, that there are lots of conversations happening in the background. Different organizations are advocating and showing the results of eConsults, the financial results, the expanded access, and all of that. So I know folks are doing that. I just don't know if there's a concentrated, larger group effort to have those conversations.
Yeah, I think there is. And if any of you have not read a Milbank report that was put out around, I think, March or April, I'd be more than happy to share with this group, because it really kind of does speak to the quadruple aims and the idea about how eConsult fits into all of that sort of thing. But at the end of the day, I think we will have to demonstrate that this can be done in a safe way, in an efficient care manner with those sort of outcomes. And at the end of the day, we all know that HCPF wants to know that it's not going to cost too much money, or that they can save money on it. So those are the things that we'll have to answer in order to get their buy-in, frankly. But on the other hand, as I've talked about cost, pardon me, they come to the table too with the idea that we want to know that people like it, and patients and providers are okay, and that they like it, and there's good satisfaction, because I do think that there's a lot of worry about a question that came up about the cost, and if it's not communicated correctly, and that's across these different groups. So let's say the PCP does have that interaction with a patient and says, listen, we have a new possibility here. And what I want to do, because you're doing so well with the management of your diabetes, I'm going to say you don't need to come into my office or go to the academic medical center this next time for your visit. If you're okay, I'm going to, with your data, present it to Dr. Wadwa or whomever at Anschutz, and then based upon your data and everything going well, we'll communicate back to you that you're doing quite well. Now, that would be a perfect scenario, but it could also end up being screwed up if the wrong communication is, or there's some payment that comes through or some cost that comes through that the patient hasn't been communicated to about, that could end up messing that up. So I think right communication, right partnership, bi-directional communication, and engagement by all parties equally to say this is the right approach needs to happen.
If you have that report and are willing to send it my way via email, we can share it in our follow-up email to the whole eConsults group.
I'm happy to.
Thank you.
So I know that we have some other folks on the call from Denver Health and our Kaiser or some of our FQ partners. Is anybody else aware of anything else around advocacy or policy or just thoughts around what's happening in Colorado with eConsults?
This is Beth from Denver Health. I typed Heather a long message, so I just, my feelings are just rip off the Band-Aid and we need to get payment. I mean, we could spend 5 more years, 10 more years on this, and I mean, we've proven it federally. This isn't happening. We've proven it nationally. Other states, Medicaid, are paying for it. So I don't know how long we run in circles. I talk about the same thing and the same results. And, you do have to have programs and training for people. You want more and more organizations, small, medium, large, to join and learn how to do this. And of course, there has to be a platform for minimal documentation and expectations. But I don't know. Maybe it's just me because I've been in this for so long, but I'm just a little burnt out talking about how we can do it better. I'd love to have some kind of reward to move forward on a big scale.
I hear you, Beth, because I think that there has been a lot to justify and say that eConsults are effective and that they do work. And so you're ready to rip the Band-Aid off.
Yep, I'm ready. Whatever we have to do.
Because I will, and I may be a cockeyed optimist or willing to take to continue to be beat over the head. But I really do think this is one of those times. It's like we have the right sort of mechanisms, we have the right sort of timing, we have the right sort of demand, and we have frankly, the limitations of a payer system that sort of position us right now to have this be something that could move to that next level. And you could, if you want to laugh right now or mute and laugh, whichever's fine, but I would love to have these conversations with you because Bill Berman and I were talking about you the other day related to we should get together and talk about how we combine our efforts or our data to demonstrate impact.
Agreed, yes. And I got an email today from you guys, so I'll respond and we'll set up some time.
See, this is the value that we bring. Look at this. collaborating and finding ways to connect. Lynette via chat also sent an evaluation of the Kaiser specialty care program that speaks a bit to the provider and patient satisfaction, because I think that that's another outcome that sometimes gets overlooked. We look a lot at the clinical piece, but ensuring that we're also ensuring that patients and providers find it to be beneficial and that they have good satisfaction around it. So just being aware and cognizant of everyone's time, I'm curious, what are we not already doing around this that we should explore? Are there blind spots, or are there ideas on additional things that we should be considering?
This is Beth again. I do think we need to go after some of the smaller doc shops, and some of the University of Denver Health, some of the Kaiser, some of the big areas are using it, and we're all partnering with different clinics, but I think that we need to go on a larger scale with the smaller clinics as well. And it might incentivize more providers for Medicaid and what have you. So.
This is Dee Dee, and I had one other thought that I think it's a group that hasn't been brought directly into this conversation and is also part of the advocacy world, and that is people or patients themselves, right? About, them asking, why don't I have this? Why don't I have telehealth? I don't have eConsult. When are you going to get on board with that? Because I don't think it's been advocacy groups and providers, but I'm not sure we've had direct patient involvement as advocates.
I think you're right on, Dee Dee. And that sometimes, I will say that I think there's sometimes in some areas a bit of a mutually dependent relationship between patients and providers who may need to be told, you're doing so well. Why don't we actually do your care in a way that you don't have to come to the campus? And then telling providers at the campus or other entities, this is the right way to do it, and it will save the system money. I know that that's it's very simplistic, but the idea about the appropriate sort of use of care, again, I think it will require some patience. Speaking of stories where, I sat right in my home, and for the last year, I've been managing my diabetes quite well. And I get my information from my provider. I go right to my local pharmacy, and everything's copacetic, and I spend my time enjoying myself on my bike, et cetera, without driving to Denver. So I think it will.
Yeah, and I would take that one step farther, and it'd be somebody managing their care saying, why can't I do it remotely? Not that you've offered me this choice.
Yeah, I agree. Yeah, I agree.
And I think that that's a specific role that the alliances can play in all of this. We can help with really bringing patient voices to the front, and having them verbalize their experience and what their wants and needs and it's what their preferences are. I think, back to some of my previous work at Stride, we had a lot of patients who really couldn't mobilize to get themselves to university. It actually required us getting an ambulance to take them, some of our quadriplegic patients or patients that were bedbound. The cost it took to get them to their specialist was just exuberant. And so there's people where physically it's painful to try to go in person, or it just costs a lot. So if it is really a patient preference and it's something that they want to see happen and it really empowers them in their healthcare experience, I think working together collaboratively to bring those voices to the state will really be impactful. So I agree with Dee Dee's idea. I think it's great to have data, and I think it's great to show, the benefits. And they do hear a lot from providers. They don't hear as much from patients.
Good point.
Other thoughts to consider? And what will this look like in 10, 20, 30 years? It'll be just so interesting to see, right?
Well, I hope so. This is my 18th year in telemedicine. So, relative to the difference of 18 years ago to this, you know, there's a lot of differences, but there's still a lot of similar kind of barriers or worries about I mean, you know, it always makes me sort of not tear up, but it irritates me to see the same barriers mentioned in a paper when they say, here are the existing barriers happening around telemedicine. And they get to the same stuff. It's the lack of access or the lack of broadband, or the lack of payment, or those sort of things. It's like, come on, people. So some of those are still not dealt with.
Right. Yeah, there's definitely the social determinant considerations. Well, the conversation does not end here. Both alliances have priorities, you know, around access to specialty care. Both alliances have groups that meet and convene around access to specialty care. So if you're not already linked in with the Mile High Health Alliance or the Aurora Health Alliance, I really encourage you to go to both of those websites and learn more about specialty care access and what those work groups are doing. They continue to convene, and this will continue to be a topic that's discussed. So it's been great to have this webinar series. And I just want to say a big thank you to everyone that participated. It's great for everyone to get that baseline understanding and educate ourselves. And so we can figure out, you know, what our individual organization's role might be moving forward, and then collectively as alliances and just individuals in our community, how can we help further this work? So great dialogue. Thanks, everybody.
I echo that. Thank you so much. I wanted to extend a thank you to all of our speakers throughout the series and Fred today. Our planning committee, believe it or not, this has been in the works for 6 months. So we're excited to have today come. We'll be compiling recordings of all of this, and the resources that were shared throughout the webinars. We'll be emailing those to all webinar registrants probably next week. So thank you all so much. Stay tuned, stay engaged, and stay COVID safe out there.
And thank you for using echo there in a way that I'm very, very cheesy about the use of echo in a, you know, let me echo that, or
Oh,
bad jokes. I'm full of bad jokes. There you go.
Someone gets my humor. Yes.
oh, that's great. Enjoy the rest of your day, everybody.